Because of its association with death from aneurysms, myocardial infarction, heart and renal failure, and stroke, hypertension is the #1 risk factor for death worldwide. According to the CDC, hypertension as a primary or contributing cause killed 360,000 Americans in the year 2013. That's almost 1,000 people a day. Of all cardiovascular disease events, an elevated systolic blood pressure above 115 millimeters of mercury causes 45%. This is in contrast to elevated cholesterol, resulting in 28% of cardiovascular disease events, and overweight and obesity account for 15%. The Global Burden of Disease Study assessed cardiovascular disease burden attributable to non-optimal levels of systolic blood pressure, cholesterol, and BMI. The burden for blood pressure was related to deaths and disability-adjusted life years from ischemic heart disease, stroke, hypertensive disease, and other cardiovascular diseases. In the year 2000, 7.1 million deaths were attributed to high blood pressure, which was shared equally between men and women. A recent analysis published in the Journal of the American Medical Association found that the number of people worldwide with systolic blood pressures greater than 110 increased from approximately 73,000 to 81,000 per 100,000 people between 1990 and 2015. And numbers of individuals with systolic blood pressures over 140 increased from 17,000 per 100,000 to 20,500 per 100,000 people. Additionally, annual mortality rose from 136 to 145 per 100,000 people among those with a systolic blood pressure of at least 110 to 115. And death rates increased from 98 to 106 per 100,000 people for those with systolic blood pressures of 140 or more. Hypertension is also costly. In 1998, $109 billion was spent on hypertension, or about 13% of the healthcare budget. And hypertension is rampant. 1 in 3 American adults, or approximately 78 million people, have hypertension. In America, as well as in most other Western populations, blood pressure increases with age, so that by age 60, 65% of Americans will be hypertensive. The global hypertension market in 2002 was worth about $36 billion, and the top 4 blood pressure lowering drugs alone accounted for yearly sales of $8 billion. Other populations that do not see this age-related rise in blood pressure include mostly rural indigenous groups. One such group was composed of rural native Kenyans studied in the 1920s. These people ate a low-sodium, whole plant food diet, and by age 60, their average blood pressure was 110/70, as compared to their Western counterparts at an average blood pressure exceeding 140/90. During the 2 years that these people were studied, there were no cases of hypertension or atherosclerosis out of 1,800 people that had been admitted to a local hospital. Epidemiological data on blood pressure, cholesterol, and body weight levels are predominantly available from developed countries. However, evidence indicates that these risk factors are important and increasing in many other countries. Surveys in developing countries suggest increases in these risks occur early in the path to industrialization. Good evidence also documents risk factor levels rising after people migrate to more urbanized settings in Africa, China, and the Pacific Islands. Another population that maintains average blood pressures of 100/60 from adolescence through old age is the Yanomami Indians of Brazil. These people, too, eat a very low-sodium diet high in fiber. They also do not consume alcohol and are very physically active. Obesity and hypertension are completely absent in this society. The definition of hypertension is arbitrary. There is a continuous association of blood pressure and cardiovascular disease risk such that any blood pressure above 110/70 poses an increased risk of both heart attack and stroke. Data showing that lowering systolic blood pressure by 10 millimeters of mercury in patients with hypertension reduces cardiovascular and stroke mortality by 25% and 40% respectively. Recommendations from JNC8 state that in the general population, pharmacologic treatment should be initiated when blood pressure is 150/90 or higher in adults 60 years and older, or 140/90 or higher in adults younger than 60 years. And in patients with hypertension and diabetes, pharmacologic treatment should be initiated when blood pressure is 140/90 or higher, regardless of age. Optimal blood pressure targets for pharmacologic therapy is considered 120 systolic over 80 diastolic. While lowering blood pressures to this target reduces the risk of cardiovascular events significantly, it does not eliminate the risk because of this continuous association. In addition, we know that in order to prevent one stroke, we must treat 118 people with diastolic blood pressures in the range of 90 to 110. This number needed to treat declines as the diastolic pressure rises. For pressures between 110 and 115, 52 people must be treated, and 29 require treatment to prevent one stroke when the diastolic pressure is above 115. Another way to look at relative risk reduction, absolute risk reduction, and the number needed to treat comes from Cook and Sackett. In this study on hypertension and stroke from Collins et al., the risk of stroke over 5 years for those diastolic blood pressures above 110 is 15 cases per 1,000 patients for those that are untreated, and 9 cases per 1,000 for those actively treated with medications. The relative risk reduction is 15 minus 9 divided by 15, or a 40% reduction in stroke over 5 years. This seems quite impressive. However, the absolute reduction in stroke from treatment with medication is 15 minus 9 strokes, which equals only 6 strokes prevented after treating 1,000 people with medication for 5 years. In other words, approximately 1 stroke is prevented each year by treating 1,000 patients. Absolute risk reduction and the number needed to treat need to be considered carefully to determine whether or not the benefit of the treatment is worth the potential risks. Lowering blood pressure to levels less than 120/80 with drugs poses its own risks because of the concept of essential hypertension. The concept of hypertension being essential means that as blood vessels become diseased and sclerotic, a certain pressure must be maintained in order to perfuse the vital organs. Increased risk of hypoperfusion of the brain, resulting in dizziness, falls, and strokes, and hypoperfusion of the coronary vessels, resulting in myocardial ischemia, is the reason for the J-curve phenomenon that is seen when blood pressure, particularly diastolic blood pressure, is lowered pharmacologically below a certain threshold of 70 millimeters of mercury. This phenomenon is only seen in the case of conventional pharmacologic intervention. When reversal of hypertension is achieved through application of lifestyle treatments, this phenomenon disappears, and only then can stroke and heart attack risk be eliminated.